my room. That's how I'm referred to around here by the caregivers, med aides, nurses, the staff people, talking to one another about me. It's that way with every resident. When I say here, I mean one of the assisted living facilities in my community. The acronym is ALF. I do have a non-numerical identity too. My name is Dick. That's what my friends in the real world call me. But Richard is the preferred use in the ALF. I can see why a room number replaces a name in the world of ALFs. It protects people's privacy, unless you've been living here a while and know who's in which room. However, I don't mind if other residents know my pain pill dose has been changed, or I use fiber. Most people here do, to regulate their GI system. Anyhow, that's a conversation starter among residents. Most old people like to talk about their bowels. I especially would want my friends and people at my dining table to know if I'm sick, even dying. They're my friends and they care about me. They shouldn't be rebuffed when they ask after me. Too often administrators refer to HIPAA, the acronym for the Health Insurance Portability Protection Act. And residents are blocked in their inquiry to learn about an absent friend. I wonder if other residents feel the same as me. I only speak for myself. In the next several minutes, I'll take you on a personal journey through parts of my days at an ALF and how I think and feel about how I live. This is strictly me, a person who's always been engaged in life, physically, intellectually, creatively. Now I find my independent spirit curtailed, but I strive to hold on to it, walking along the thin edge of dignity in the complex world of assisted living. I don't really walk. I'm disabled and in a wheelchair. I use the word metaphorically. I began life in ALF in 2006 after a disastrous motor vehicle accident. I was dead at the scene, suffering broken legs and arms, plus other multiple breaks, fractures and burns, and nerves and tendons and such were all affected. I was damaged goods, but I was resuscitated and put back together, sort of. After 9 months, I was rehabilitated, but disabled. As I said, I'm in a wheelchair and only one hand works, not very well. So you see, I need an assisted living facility. People like me depend on the niceness and kindness of other people. I'm glad I've had the opportunity to participate in random acts of kindness by strangers and committed acts of kindness from friends. Here in ALF, kindness is in the everyday care of a staff of caregivers. They're paid to help. I hope that care is in their hearts. If so, it will be in their help. My need is for doing those simple activities of daily living, those piddling things you never even think about. Take two specific and usually ordinary and seemingly insignificant actions. A cup of water is poured for me and set on the counter. A glass usually would be suitable, but my fingers can't spread to go around the glass. Ordinarily, I'd reach out for the cup, grasp it by one of its handles, and drink. Now that I'm seated in a wheelchair below the counter, if the cup isn't placed close to the edge, I can't reach it. And since the fingers of my left hand are stiffly immobile and curved into a partial fist, if the cup handle isn't accessible to or handed to my right hand, I'm unable to grasp the cup. No drink. Another incidental and habitual action. My glasses need to be cleaned. A caregiver wipes them for me, closes the temples of the frame over their lenses, and lays the glasses on the table or desktop. I have to pick up the glasses with my right hand, Spread apart the temples by grasping the left temple with my teeth. Balance the frame on my thigh. Raise the right temple with my right hand and slip the tilted frame over my eyes. Better for the person who cleans my glasses not to close the temples over the lenses as is ordinarily done. It's unnerving not to be able to do what I need when the moment for doing is now. I'm frustrated and discomforted when help isn't there, when there's an urgency. I have to pee. No one comes. I have to have my coat put on. My ride is here. The caregiver isn't. I need to recover my glasses that fell. I can't see without them. Where are you? The worst is when I'm left sitting on the toilet for more than 15 minutes. I hesitatingly get up and put a towel on the cushion of my wheelchair. With my reefs and pants clinging to my ankles, I shuffle in my wheelchair to the hallway and shout for service. Usually someone hears and finds a caregiver to rescue me and give me the wipe I need. If you've lived an independent life as I did, and have an independent spirit as I still do, it's hard to get used to ALF life. When I first became 108 in 2006, I discovered the rigid time synchronization of this life. The previous 108, the person who had lived in the room before me, had posted reminders of her eating times on the door of her refrigerator. Breakfast is at 8, and morning caregivers scurry around, making sure that everyone is in their place in the dining room. Lunch is at noon, more hustle and bustle to get residents seated. And supper at 5, when evening caregivers push you along. There was an order to things, no happenstance, managed dining. When I'd been away from the ALF and ready to return, working out at my fitness center or finishing my volunteer time at an elementary school, and I'm waiting for the bus which transports the elderly and disabled, I start to stress if the driver is late and I might not get back in time. I know when I return the caregivers will be busy getting residents into the dining room. I'll need to break into the helter-skelter of their getting residents in their places. I have to be taken to the bathroom, washed, and redressed. While I'm waiting for my ride, I worry I won't make it to the ALF in time for the caregivers to get me before the designated meal time. In the afternoon, I usually go to coffee with friends. Just when the conversation is warming up, I sense that it's time to leave the coffee house. It's the same anxious feeling I had in the morning. To be back, to have a caregiver available to take my coat off, to take me to the toilet, wash me up, before I'm lost in the scurry of shuttling residents to their place. Nights can be even more stressful. I often have a chance to go to dinner with friends, to movies or concerts or lectures, activities that are only held at night. But shower time is usually at 8:30. 9 o'clock is stretching it. I fret over the time instead of enjoying the event. I may even reject the invitation to go out, weighing the opportunity to have fun with being assisted in something I once was able to do myself anytime I wanted. That's time management, an integral product of the synchronized living of an ALF. Speaking of showering, that's one of the long-term care industry's activities of daily living, or ADLs. If needed assistance in a minimum of 2 ADLs, you're eligible to live in an ALF. How about those acronyms? I'm deficient in the minimum of 2 ADLs and then some. It's enough to cost me $4,700 a month to live here. Research shows that bathing, toileting, and dressing are the most needed ADLs. I get help with each. Together, they make the thin edge of dignity hard not to fall over, especially when I'm taken to the bathroom. Using the toilet is one of those personal intimacies that I share with a caregiver. After she pulls down my pants and jockey briefs, I purposely avoid wearing button zipper belt pants to simplify the process. I can't stand in front of the toilet and maneuver my hands and fingers to make the needed extraction. So I sit to urinate. The caregiver waits. I pee. She pulls up my briefs and pants. That's okay. The mature woman will try to wipe off the head of my penis with toilet paper. That's less okay. A bowel movement can be emotionally degrading. After finishing, I rise from the toilet, grasp the handicap bar to the side. I turn my back to the caregiver and bend over, legs astraddle. I feel the cold, moistened wipe as the caregiver wipes me. Then a further wipe with dry toilet paper. I feel isolated and uncomfortable, just standing in place, my back to the caregiver, waiting for the wipes. Taking a shower includes being undressed and this intimate waste processing. After being wiped, I'm undressed. Uncovered and vulnerable in my nakedness, I sit on the shower bench, my hands folded on my thigh. I shiver, waiting for the caregiver to turn on the water. I think about the Nazi strategy of stripping prisoners before interrogation. Images flash through my mind of the humiliation of Abu Ghraib in the Iraq War. Far-fetched, of course, but the images appear, the thoughts occur. Then the warm water rains down. When I was being put back together in the hospital after my accident, my children fixed up my house and sold it. They realized that I couldn't live alone and that I needed long-term care, or LTC. As we've seen, the health industry, like the military, has an acronym for everything. The decision was made. I would be placed in an assisted living facility, out. I was on to deliberate the options. So one afternoon in March 2006, my son pushed me through the doors of an out. After greetings with handshakes and nice to meet yous, I looked around. I saw a long hallway and closed doors. People standing or milling around. Announcements on a corkboard, numbers on a panel of mailboxes. A huge room filled with tables and chairs. All of it's going to be my new home. Okay, I'm here, I thought. But exactly where am I? What do I do now that I've become 108? After 8 years, I've got it all figured out. But I still see new people come in, and I wonder how they'll feel when they're put at a table with other residents. If they're lucky, they'll be introduced and asked to stand up in the dining room and face strangers' eyes, try to mumble something polite. The administrator asks everyone to give them a hearty welcome and to applaud their presence. That night, the new resident will sleep in a strange room, maybe in her old bed, all alone for the first time in perhaps more than 50 years.
How'd you sleep?
An okay slips between her lips. It would have been nice if there had been a transition from an active life in the world into a facility. Many people who enter here are swept from their ties with neighbors and other people they knew, with no expectation of the kind of new life that they'll be living. I was fortunate, since I had come to the ALF from a skilled nursing facility. A SNF. Here we go again with acronyms. SNF living was like living here, with rehabilitating residents, nurses, and caregivers. I thought I knew what to expect. But I wasn't prepared to learn that most people residing in here stay in here. They don't go out. My life had been characterized by being out, running, swimming, lifting, bicycling. I had biked all over town all the time. I was known as the guy in the yellow rain suit. I had gone to coffee houses, taking classes, attended meetings, gone to movies and concerts, always on the go, wherever my spirit of independence took me, engaging my physical, intellectual, and creative selves. Sure, each facility has activities and minimal exercise, only not what I was used to, nor wanted. The activities here appear to fill the time, like a trip to Kmart or Safeway, a ride in the country sealed in a bus. But my dissatisfaction is me. I can't speak for others. I choose to live in the world outside the ALF. Most residents choose, or have no choice, to stay. This is their environment. They're in all day, except for doctor visits. This is especially true for those with Alzheimer's and dementia. My wife had Alzheimer's. She didn't need assistance. She needed care and was in a facility which specialized in caring for her. What I saw in her Alzheimer's dementia facility, I also see here in an ALF. People who just sit in the same chairs throughout the day, people who talk to themselves, who aimlessly meander the halls or stand still, waiting for a caregiver to show them where to go. Even those who walk away from the facility. It's not a healthy, vital atmosphere to absorb. Thank goodness it's not catching. But in a sense, it can be. And hanging out is not just exhibited by the residents who live in the fog of dementia. Even those who are cognizant and have mobility close themselves in their rooms until meals calls. Where's the energy, I wonder? Where's the productive life? It's not in bingo or Yahtzee. These activities fill waiting time until death. Am I unique to avoid them? Do others in the ALF have longings to explore away from here? Can we not provide for residents who want to do something in and for the outside community? These questions could be answered if there were a welcoming band of brothers to greet new residents. The analogy is the old-fashioned community welcome wagon, a group of residents who would provide personal interaction between current residents and a newcomer. The newbie wouldn't have to search out people to meet or be stuck with those at the tables she'd been put at. The ALF wouldn't be a strange, mystifying confinement. Meeting one like ourselves could make newcomers feel at home. In these several minutes, I've tried to summarize my feelings of the experience of living in an ALF. It's not been a happy or content time. There's always that itch to live as I did before. I'm not psychologically ready to live institutionalized. Physically, I am. That's why while living in an ALF, I've engaged in the outside world. I teach, volunteer, write, take courses, work out. I pursue acts of giving back to society. I think that's what one who is living long, like me, should do. It's been said that it takes a village to raise a child. The unspoken corollary is that it takes a village to accompany the elders on the final journey of life. But in today's fragmented and mobile society, families no longer live together in a single household. Once it took a village. Today it takes an ALF.
What do we think about that? How does that make us feel? What's that? Sad.
Press.
Depressed? Okay. So why did I show it? So we can see how they feel. So we can see how they feel. Yeah. Maybe so we can do something about it. So we can make life different. Be more purposeful, more meaningful, give them more choices, not the production of meals. And you notice his anxiety that he has to be back before 8:30 or he doesn't get a shower, that he can't go out with friends. All right, so we're going to divide up into groups of 4 to 5, if we can. All right, divide up. What?
4 or 5, not 2.
To come up with 3 things that we do well here in the Village of Rehab in relation to patient care. Our patients are the center of our universe. So what are 3 things that we do well? So I'll give you a few minutes to talk about that. Let's go with this group back here first.
We interact with them.
Huh?
We interact with them.
Interactions, okay, that's great.
And encourage them to
Encourage, okay. We do what? Results. We give results. All right.
We resolve any issues.
Okay, so we resolve issues.
We provide excellent food. Yes.
Good food, okay.
We don't have to wait for
Choices.
They don't have to wait for showers. Good customer service.
Yeah, choices, good food choices.
And we safe environment.
Rehab, okay. That's results, yep. What else? Activities, teamwork, okay.
Care plan.
Activities, okay.
Safe
Over here,
environment.
safe environment.
Bilingual staff.
Huh?
Bilingual staff.
Bilingual staff, okay. That's activities. What else? What else do we do well? Emotional support.
On the other side, wait.
That would be more patient-centered.
Train them, make sure they didn't reach their food.
All right, so somebody tell me, what did this group decide we could do better?
Well, we were talking about response times with answering lights.
Retain competent staffing.
Also knowing what to do and like if someone says code blue, knowing what that means and what to do in that instance, what role you should have in that.
Okay, so like, what are you saying? Like, is code
and-
just a example, or is that's specifically what you're talking about?
Well, it's an example, like in emergency situations, knowing what that situation means, what your role is, knowing what to do.
Okay. What else? This side of the room?
Residents' likes and dislikes.
More, what is it, like what she was saying, 2 persons in a chair, is that what you're saying? Okay. so, let's see, how are we gonna word that one?
We need to do more of it, I think is what she's saying.
Dignity? Okay, what else?
Communication amongst staff members, like between rehab and nursing and CNAs and all that.
There's probably communication all the way around. Between patients, families, staff, residents, the whole gamut, right?
How about dementia care training? So more people know what to do when you have a resident that's sundowning or exit seeking. Know how to redirect.
Okay. What else?
How the CNA to float. CNA on the floor, that would help.
Oh, so, okay, so that would be a solution to a problem. So tell me what
That
we're
would help
trying to.
answering lights wherever somebody needed help.
Oh, so you're saying that would help with all of these
Yes,
needs?
I do.
Okay,
Especially during mealtime.
so maybe increase staffing during mealtime?
Well, at least have an aide on the floor to do it patients
That would be perfect.
meals.
Okay.
What do you think?
That works. What else? Anything else? All right. Okay, so with these in mind, we need to now prioritize what we want to work on first. So look at your list. I'll label them. Can you guys see the list on this side? Okay, so the list is number 1, work on response time for call lights. Number 2 is retention of competent staff. So maybe that's turnover. I would see that as an employee turnover. Number 3, knowing emergency situations. Number 4, person-centered care and preferences. Number 5, treating patients with respect and dignity. Number 6, increased communication. Number 7, dementia care training. And number 8, increased staffing during mealtime.
Doesn't number 5 sort of cover all of that?
No, not really.
Except for that last one, maybe.
Not true. All right, so with a show of hands, I want to see who, now you're voting only for one. You get one vote apiece. I'll be watching. Fred has the camera.
But wait a minute, a couple of those kind of like, I would think call lights and increased staffing. I think it should be more like, we need to somehow support the CNAs for those two things.
Now, we're not looking at solutions right now.
Okay.
We're only looking at which goals do we want to concentrate on right now. So we're going to take one goal at a time, and this is going to be what our facility as a whole, what we're going to work towards. And we'll work on a plan. So everybody gets one vote. Got that? So everybody in favor of number 1, raise your hand. Okay. Number 2, raise your hand. Number 3, raise your hand. Well, you guys are waiting for something. Number 4.
Number 8.
Number 4, raise your hand. 1, 2, 3. Okay. Number 5, raise your hand. Kay is voting. Wait a minute, raise your hand high for number 5. 1, 2, 3, 4, 5, 6. Okay. Number 6, raise your hand. Ah, that's what you guys are waiting for. 8, 9, 10, 11, 12, 13, 17, 18, 19, 21, 22. Does Gloria even know what 24? Okay. Dementia care training. No? And number 8, increased staffing during mealtime. Raise your hand. 1, 2, 3, 4, 5, 6. Even up 7, 8, 9, 10, 11, 12, 13, 14, 15.
Everybody that come help on meal times, Debbie.
That's right. All right, so our goal that we're going to start working on next week, we'll all get together and we'll work out a plan for communication. That'll be first. And then our secondary goal will be increasing staff improvement. Obviously, that's important to everybody. All righty, there's food over here. You guys are welcome to it. Thank you very much. I appreciate it.